Let's start with our next session. The next session is secondary IOLs. Now that we have started doing phaco, we have started with the phaco in the last session. Anyways, we have to deal with complications. We have to come out of the complications. We anyway will have to be having hands-on with any kind of secondary IOL. At least one you should know. Then only you will have a way out. So let's learn secondary IOLs, the different kinds of secondary IOLs, what practical tips that we can have. We'll start with the session. I am Dr. Lakshmi. I am from Giridhar Eye Institute, Kochi. I'll just start with the introduction, indications, planning of secondary IOLs. So, secondary intraocular lens implantation, indications, planning. I'll be also talking about AC IOLs. So, what is secondary IOL implantation? Implantation of an intraocular lens following an initial surgery that resulted in aphakia or a deficient intraocular lens. What can be the indications of secondary IOL? IOL exchange, as in incorrect IOL power, IOL subluxation, opacification of IOL, photopsias, dissatisfied patient with multifocal IOLs, IOL-induced inflammatory response and cystoid macular edema, IOL-induced endothelial decondensation, IOL removal, and later secondary implantation in chronic endophthalmitis. After congenital cataract surgery in children less than 1 year, after complicated cataract surgeries, the most common, trauma, uveitis, and after refractive surprise. Patient selection is one of the main things in secondary IOL. History, very important, because you have to sit with the patient and take a detailed history as on the timing of the previous surgery, the type of surgery, the trauma in detail, what kind of trauma it was, like what investigations is already done. If you have an EMR access to the already, or the case record access to the already done surgery, it is well and good. Refraction definitely needed, because you need to know how much vision the patient can get after the secondary IOL implantation. So a detailed anterior segment examination, including the conjunctival status, including the presence of glaucoma drainage devices, because when we are planning the surgery, there are many options of a secondary IOL. So which option to choose depends on the examination of the patient. Cornea, clarity, edema have to be noted. Pachymetry, yes, should be done. Specular, definitely, if to assess the endothelial cell count, especially when you are doing a AC IOL. And yes, chamber depth, vitreous prolapse in AC, you have to note. Even a white to white diameter also can be done. Iris and the capsule status. See the patient undilated before dilating the patient, because if you're planning an iris claw lens, you need to know the pattern of the iris, how the pupil is before, and whether there are thin areas in the iris before doing that. Always see for the incisions in the primary surgery, like whether an SICS was done, whether any retina procedure was done, whether there is a buckle, you have to see before. That means examination is really important before you proceed with or you plan the secondary IOL implantation. If an IOL is present, the degree of subluxation and the type of IOL, because when you're planning a secondary IOL, can the primary IOL be reused? That should be kept in mind. So the type of IOL should always be looked forward. The timing of the prior surgery, whether the SICS wound would have healed 5-6 years back, the SICS was done, whether we can open the same wound or should we make another wound, all depends on your examination or the anterior segment examination of the patient. Posterior segment examination is valuable in case that some conditions limit post-operative results. That means we'll have to definitely keep in mind whether the patient will improve after doing a secondary surgery, whether we are going to incite inflammation, whether the retina is good or bad, because after doing the surgery, the patient should get some vision. If the patient is not going to get vision, should we definitely take the patient for the surgery? That should be kept in mind. And one advice is always, if there is a subluxated cataract or if there is a subluxated lens, make the patient lie down and see how the lens dangles, like if it is in the mid-vitreous, because when we sit, if there is a superior attachment of the lens, we cannot see that. But when the patient lies down for the surgery, then you'll have to definitely have a retina backup. So the retina backup we should already tell to the retina persons, otherwise they won't come for the retina thing. So keep in mind, make the patient lie down and see the patient, see where the lens is. So that is regarding the patient selection and the criteria before considering which type of lens or which type of secondary IOL that should be, that the patient should undergo. So the options are a single piece or a 3-piece foldable IOL in the back, or a 3-piece implantation in the sulcus. AC IOL, iris fixated, can be anterior or retropupillary, and scleral fixated lenses in many forms. Determination of anatomic location of the secondary IOL. Choosing the best location and technique for secondary IOL implantation can be a difficult one, and there are no clear guidelines that this lens should be used for this patient. It is our criteria, like which type of surgery or which type of implantation we are comfortable with, definitely has a role. Recommendations in ruling out certain anatomic locations for IOL fixations. That is, if the endothelium is poor, like poor corneal endothelial status, abnormal iris angle anomaly, then AC IOL, no. Lack of adequate iris support, you cannot put in an iris claw lens. Lack of posterior capsular support or a fibrosed anterior or posterior capsule would rule out in the bag IOL placement. Sulcus IOL placement can be done if the anterior capsular support is good. Scleral abnormalities always should be looked forward before doing an SF IOL, like in Marfan's, when there is scleral thinning, chronic uveitis, etc. should be ruled out before doing scleral fixation techniques. All these things should be kept in mind before doing the surgery. Simple algorithm. A patient planned for surgery, if the anterior capsule is intact and if the bag is quite good, go in for in the bag placement of the IOL. If it is not there, if it should be placed in the sulcus, go in for a 3-piece IOL. If intact anterior capsule is not there, and if there is a sufficient iris tissue, I have already told that you have to see the patient undilated. So go in for an iris fixated lens if there is sufficient iris tissue. And if it is not there, see whether a pupilloplasty can be done in case of trauma and all. If definitely iris is quite good, the pupil is quite round and all, you can try in an iris claw, but better go in for a SF IOL. You can put the secondary IOL in the capsular bag in the early postoperative period before the formation of anterior and posterior capsular adhesions. Ideally, it should be performed 4 to 6 weeks of within 4 to 6 weeks of the initial cataract surgery. Although in the bag IOL exchange months to years have been reported, but it's quite cumbersome. A few words about anterior chamber intraocular lens. We are all putting iris, claw, bar, SF IOL in many forms, but there are people putting anterior chamber intraocular lens even now. Baron was the first to implant an anterior chamber IOL in 1952. Closed loop AC IOLs in 1970s. Open loop in 1980s, 1990s, all were open loop designs. Even now, we have very modified versions of the open loop AC IOLs. Angle to angle measurement measured by UBM or OCT, if you are planning a secondary IOL, can be done, but on the table you can do a white to white distance measurement and intraoperatively with calipers, and 1 millimeter is added to the size of IOL before putting in an AC IOL. So when you put in an AC IOL, the size matters. So that's why they have already told white to white measurement is needed. When you put in if it is not available, only one size of AC IOL is available. When you put in an IOL, see whether it is very tight, whether the pupil is stretching too much. That means it is going to create trauma to the angle. There can be, because once you put in the lens, the patient develops many complications. The patient will tell, no, before surgery it was very good. Only thing I couldn't see. After surgery, every day I'm having pain. It will be really difficult for the patient and the surgeon, because every day the patient will be coming. Long-term steroids may be needed, and also keep in mind that adequate sized AC oil, if it is available in a secondary IOL procedure, that will be ideal. Just going into a small video, this video courtesy Dr. Sai Kumar. So the scleral incision SICS wound is there, pupil is round, myosed, PI is made, AC IOL is, visco is put, AC IOL is just inserted, and then you have to gently nudge the ACIL into the and the ACIL actually has to crawl in the angle, and it has to nicely sit in the angle. So see that PI is always made prior to putting in the ACIL, because after that it's not possible. And suture the wound, if it is not very tight, that will be good. Thank you.
Thank you, Dr. Lakshmi.
Our next speaker is Dr. Purnima Sheba Abraham from Girdhara Institute. She'll be speaking on sutured SFIOLs. Is a very gifted cataract surgeon. Since the last 12-15 years, she had been doing umpteen number of cataract surgeries in the hospital.
I wish everyone a very good morning and a great academic feast. Thank you, Dr. Lakshmi. I'll be vouching for sutured scleral fixated IOLs in my talk. So we know when any type of secondary IOL is indicated, but then you should also know when to avoid using them. That is very important as well. We know that a very thorough clinical assessment is essential before planning any of these procedures. Especially a very good biometry is required. Any of the newer generation formulas hold, good. They give excellent results. What to keep in mind is a myopic shift is seen if sutured IOLs are positioned beyond 2 mm from the limbus. Now, if you're taken by surprise and you plan to place an SFIOL in the primary sitting itself, you could use this rule of nines, to deduct from the intra-bag target, which you have already, which you have in your hand. Once you decide to put an SFIOL, it's time to, make a decision as to when to do the surgery and what approach to take. So an anterior approach would be an easy way, and it would be most convenient in most of the settings. However, a posterior approach along with vitrectomy is said to have less lens dislocation incidences. And whether to do it at the primary sitting itself, although it has certain advantages, always planning properly and delaying the secondary procedure would be favorable in the long term. What lenses do we have? So we have the rigid PMMA lenses as well as foldable lenses with eyelets. There are various modifications of the procedures wherein you can use regular lenses as well. The sutures that we generally advise is the 90 polypropylene or proline, which has its advantages versus the 10-0 proline, which used to be used earlier. And the Gore-Tex or PTFE suture, which is now gaining popularity for its durability, is also advised. Now, various techniques have come about from when Malbran introduced this sutured concept. But then the choice of surgery is based on the surgeon. If you're comfortable with one type of procedure, stick to it. It'll be at par with any other. Now, this video here demonstrates a 4-point fixation technique. You can see the cornea has been marked prior. This helps to, create the flaps in the right place so that IOL centration is best with that. We've done a conjunctival peritomy, partial thickness scleral flaps are being fashioned here. They measure about 3 mm. Since we'll be using a PMMA lens here, a rigid lens, we have to make a corneoscleral wound. Now, the sclerotomy is an ab externo type, that is, you're going in from the outside. The suture uses a 90 proline suture with straight needles. It is docked into a 26 gauge needle by the railroad technique, and it is externalized through the corneoscleral tunnel. Now, we have this lens with the eyelet on the haptic, which is a rigid haptic. Now, when we pass the needle, just make sure to be gentle, otherwise the haptic may break. We make another sclerotomy about 1.5 mm away from the first. And then again, this railroad technique is employed to bring the suture out back under the scleral flap. So what to note here is that the sclerotomies have to be both radially arranged from the limbus, and about the sclerotomies are about 2 mm, 1.5 to 2 mm from the limbus. Now this procedure, the process is repeated on the other side as well. Railroading being done here. So for want of time, I'm just skipping that part. The fourth sclerotomy being made and the needle being passed. So once the needle, both the sutures have been brought out, the IOL is gently slid into the AC and then introduced into the sulcus. It's gently dialed into the sulcus behind the iris. The IOL can be centered by just adjusting the sutures, and then the sutures are tied and the knots buried under the scleral flap. Conjunctiva can be closed in any fashion. Just what to note is that the aim should be to place in the sulcus, and the haptic should be about 180 degrees apart. Just keep in mind that a tilt of more than 5 to 15 degrees can cause gross aberrations. So there are various other modifications which have come by, and which are very popular nowadays. Is the 2-point Sermon's knotless technique, where multiple zigzag partial thickness bites, scleral bites are taken. The suture follows a zigzag path, and then there's no knot. The suture is just cut flush to the sclera. Or the 4-point fixation with knot burial by Beccara, which where he buries a knot by just rotating it into the globe. And all these procedures have good outcomes. There's also this double flange fixation of single-piece foldable lenses, which have been described. You could also avoid a peritomy by using a Hoffman's pouch, especially in scarred eyes. So previous literature has suggested that IOL dislocation due to suture breakage was as high as 1.2 to about 40%, but more recent studies with significant long-term follow-ups, you can see the arrow here, practically no suture breakage recorded. And more so, the more common complication would be knot erosion through the sclera, so which can be managed by avoiding knots, following knotless suture techniques. So the rest of all the complications mentioned would pan the entire spectrum of secondary IOLs. So I would like to stress that it is quite a safe and effective option and can be planned in any setting. It doesn't need any fancy equipment, and it just needs a bit of practice to overcome the fear of implanting a sutured SFIL. These are some of my references. Thank you.
Yes, practice makes the technique perfect. Thank you, Dr. Purnima, for that wonderful presentation. Our next speaker is a very senior pan-ophthalmologist, I should say. He is the medical director of Amardeep Eye Hospital. Jay Prasad Bhaskaran will be talking on iris sutured IOLs. Over to you, Dr. Sir.
Good morning. Thank you, Dr. Lakshmi, for this opportunity. So I'll be talking on iris sutured IOLs. It's a secondary option. My armamentarium is nanceroprolene always on a straight needle, which I try to manually curve to get a curved needle. The ones that are available here from Orolab are not very stiff, so it's not that good, but you can manage. You can use a regular Sinskey's hook, bend it a little so that you can retrieve the sutures. You need a pair of micro scissors, an anterior vitrectomy set, and the lens of choice is a 3-piece IOL from Johnson & Johnson. I have no financial interest. Why? Because the anterior edge is always curved. Always use lenses with a curved anterior edge. The posterior edge is, of course, sharp to prevent PCO. And I always use parabulbar block. And here I go, aphakic eye, 2 side ports, 1 main incision 2.8, 3-piece lens implanted into the sulcus, the so-called sulcus, leave the optic in front, go from the side with a 23 gauge micro forceps, catch hold of the optic, and then bend the haptic and try to bring it down. The pupil is so much constricted, but it does go and come back again, and then you just nudge it in so it goes behind, and you shoehorn the iris behind the optic. So the optic is in front, the haptics are behind. It will sit there. You can use pilocarpine so that it doesn't dilate and the lens drops down. Now you use the needle, straight needle curved. From the left side, you lift up the optic and go through the iris under the haptic and come out through the iris and come out through the cornea. You don't put a second incision. You bring out a loop using your Sinskey's hook. So loop is there. Catch the free end of the loop. That is the end that has come out through the cornea. Go 3 rounds clockwise. Catch and catch from both the sides. This is a modified Seepser knot. Do that 3, 2, 1, and then you repeat it for the other haptic. Same way. Please remember, when you go through that side port with the needle, don't go lamellar. Always go through that opening, the parasynthesis opening. You cut off the excess suture so that it is tight, and once you are sure it is tight, you gently nudge the IOL optic back behind the pupil. Ensure that there is no vitreous remaining in the anterior chamber. This is very important. You don't have any strands coming into the wounds because there is no PC here. And once that is done, you can go to the periphery and do a small iridectomy. That is an iridectomy. So 2 iridectomies. Please remember, this video is running at a very fast pace. I never operate this at this pace. It is always slow, slow and slow. And don't have 14 patients waiting when you are doing this surgery. Do it. Try to do it after lunch or first in the morning, and don't have so many patients on that particular day to operate. Another patient where you have some residual PC sitting there, shriveled with a small capsular opening you can see in the center, almost more than 180-degree sonar loss. Once again, here you are much more comfortable because you are sure that the lens will not drop straight into the vitreous, even though there is a big gap. So use OVD, dispersive OVD, dial the lens into the sulcus and lift it up. lift with two instruments, bring it up so that the optic is caught by, shoehorned by the iris, and then you go through the side port. Remember, the side port has to be, for introducing the needle, it has to be a tangential paracentesis. It's not your regular paracentesis, it should be in the direction in which you are going to pass the needle. Lift up the optic, you can see the mark of the haptic through the iris, so you can go underneath that. Try to take a smaller bite and then go through an intact cornea near the limbus. Bring out a loop, catch the free end. Once again, I am showing this 3 rounds clockwise, catch and pull from both sides so that you don't drag the iris this side and that side. Inject more OVD at that point. Go back again, use that modified Sinski. Catch, rotate 3 rounds, catch the other tip and then catch from both sides. So 3, 2, 2 or 3, 2, 1 you can put, and the third one. Remember that when you are doing this, please, you should ensure that the iris is not pulled this side, that side, then you will tear the iris, you can have iridodialysis. This has to be done in a very, very controlled fashion. And once that is done, you can cut off the excess proline from both sides. Ensure that it is reasonably well centered. Try to get the iris as far towards the limbus as possible and not toward the center to avoid some amount of ovaling or the pupil getting distorted. Once that is done, you can go behind, cut off the capsule as well as a minimal anterior vitrectomy in the center, and then you can push the lens back into the behind the pupil. Once again, let me tell you that this is a procedure you should do slowly, slowly and slowly. This is a descended eye, a PMMA lens. Now before you put it, use the lens, ensure that the haptics are intact. Sometimes the original surgeon would have broken the haptic. So ensure, inspect, and in the same position, lift up the iris and see. Once again, brought it up. This is a PMMA lens. Any PMMA lens you can use if the anterior edge is curved. It should be, most of these PMMA lenses have 10-degree angulation, so there is no issue. The same procedure can be done. This is a pseudo-exfoliation patient where you anchor on both sides. The same one is, the same lens is used, and go behind the lens and cut off the residual capsule and whatever cortex was there. And once that is done, you will invariably leave behind a small, slightly oval pupil. Exactly round eye get only in 60%, 40% definitely have an oval pupil. So if it's a young girl, probably you should not do it for aesthetic reasons. You may go for a scleral fixation. Once again, slow, slow and slow. And this is finally, the pupil is not available to hold on to the optic here because the pupil has been distorted in the previous surgery, but the iris looked reasonably all right. So I have put a bridge of tensor proline suture, which is goes from pars plana to pars plana, come out and then come back and sutured onto the surface of the conjunctiva. Then you keep that IOL over that and dial it into position, anchor the haptics, and then take off the suture. So this will prevent that lens from dropping down into the vitreous immediately while you are anchoring it to the iris. Complications, possible complications, oval pupil is the most common. You can have glaucoma, pigment dispersion, cystoid macular edema 10%, iritis, and of course you can get like iris claw or scleral fixated or scleral sutured an IOL drop. I had an absolutely good record. I never had an IOL drop till last week when I dropped one lens. Thank you. Thank you so much.
Thank you so much for the technique, sir. Our next speaker is Dr. Divya Balakrishnan. She is a senior VR surgeon at LF Hospital, Angamali. She'll be speaking on the M&A technique of SFIOL.
So thank you, Lakshmi, for having me here. So I think Lakshmi has already elaborated what are the indications for secondary IOLs or so in this, as sir has shown nicely, the iris fixation, suture fixation, then there is iris claw lenses. So when you don't have an iris to fix onto, then this might be a better option, and other option is like a sutured one. So the Yamani technique classically, or the initial described, was a completely sutureless transconjunctival technique where you don't need to open any conjunctiva, any scleral dissection, nothing was required, and a 3-piece IOL is fixed onto the sclera. So this is how the 3 points were marked. So this is almost like 2 mm from the limbus, and then parallel to that there is a 2 mm incision. So you insert the needle at this point and enter the anterior chamber through this point. So this is how completely sutureless technique. But when I started doing this, especially in children, what I found out that when you insert the 26 gauge needle through that, from the anterior chamber, the fluid oozes out and then the conjunctiva balloons up. So then it becomes very difficult to reposit the tip of the IOL or the flange into the sclera. And in post-op, when the edema subsides, you tend to see these haptics sitting right under the conjunctiva and there is a risk of erosion. So I started doing a modified technique of it. So what I do is that make a very limited peritomy, 180 degrees apart. And one point to note is that you can place it oblique, horizontal or vertical. Of late I've been doing it more vertical, which I found that it is more stable and the astigmatism is also little less by doing that. And another point you have to see is that look for any previous area of scarring. Better to avoid those areas and areas of scleral thinning. So these points as a pre-op assessment, it is very important to note that. And especially in trauma cases where you anticipate there can be a traumatic mydriasis, always assess the patient before dilatation and see how much the mydriasis is. Then you may have to plan a pupilloplasty along with this technique. Otherwise, the patient can have glare or diplopia post-op. So these some points you have to keep in mind before planning for this. And in children especially, you don't want to put a large incision to make a large scleral fixated IOL. And especially in iris claw also, in the long term, sometimes you might see that there might be pigment dispersion and then iris claw lens can fall. And in those cases also, in children also, this is a better option. So here, what I do is that limited peritomy, then you make a scleral tunnel, which is you measure 2 mm from the limbus and mark 2 mm away from this limbus like this. And you can mark a scleral tunnel. It's just like with your crescent knife, you make a small incision and the tunnel is actually just the bevel of the crescent. That is basically to push the flange tip inside the sclera so that it doesn't get exposed much. So that is the only modification which I do. The scleral tunnel can be made either a 2 mm from this one or you can mark right here. Then the insertion into the anterior chamber would be little down. So this is a modification. The materials required is a 3-piece lens is usually used and you need 2 26 gauge needle. Then you can use either a Rexis forceps or any forceps like because being a VR, I use as a max grip forceps, any forceps to feed the haptic. And if you want to become assistant independent, you can use a 240 band, a bit of a 240 band, which we usually, the retina surgeons use for NSAR clutch, or even you can use like the stopper or the that stopper of the iris hook, that can also be used in this. Anything just to keep the haptic prevent from slipping in. And you need a cautery. You can use a low temperature cautery which is available. What I do is a jugaad, which we use is, like I use a BP handle and then make it really hot with using either a air, the gas, this thing is there which the oculoplasty people use for making the prosthesis, or you can use a spirit lamp. So that is a jugaad which you can use instead of that. So this is a video which shows that you can use either an AC maintainer, so or you can, if you are planning for a vitrectomy, I sometimes put a infusion cannula pars plana. So the 3-piece IOL is inserted, and you can see in this I have not made a scleral tunnel here. It is a direct entry using the 26 gauge needle, and it is haptic is actually, and I flanged it at the same point. So this is a little older video which I never used to make a scleral tunnel in this. So the main difficulty you face is feeding the trailing haptic into the second needle. That is where you struggle actually. So what I do is that sometimes I make this entry corneal tunnel little towards the right side in fact. So the literature says when I said left side, but I found, because see, before you put the second needle, I usually engage the haptic in the corneal tunnel. So that is when it is easy for you to manipulate. If somebody finds it difficult, the classically described technique of handshake technique can also be used. But I find it very comfortable. What I do is that after I have exteriorized this haptic, I tuck the trailing haptic in the corneal tunnel, leave it there, then pass the needle through this, then use the McPherson forceps to feed this. I'll show the next video. To feed the trailing haptic. So I usually mark 180 degrees, then do limited peritomy. So this is 2 mm, very small scleral tunnel. You can see just the bevel of the crescent, that much is enough. This is a 240 band which I usually feed, that only for one side it is needed, where you exteriorize the leading haptic. So this is a previously operated, you can see that severe pass in that area. So I try to release that pass. And the IOL is injected into the anterior chamber. Now I make a side port. So you need a side port to introduce the forceps there. So this is a 26 gauge needle. So 1 mm horizontal, and then you enter vertically and visualize the needle tip in the pupillary area. And this step is easy. Now you can see the 240 band or the iris hook stopper, you can just actually fit. So this helps to prevent the slippage of it. So this is the little difficult step, and in case if you find difficult that pupil is not dilating, you can use an iris hook to retract the iris in that area so that it is easy for you to feed the trailing haptic in there. That is one tip a technique which I use whenever the pupil is non-dilating, or in case if the iris is getting stuck in there. And the tip is flanged, and sometimes, see, the good thing about this is that after you exteriorize the haptic, suppose these eyes are little small and you feel that external haptic size length is more, you can actually trim it equally on both the sides before flanging the tip. So then, and push it so that it doesn't go slip posterior. So these are the few things which I modified because I found it over the long term, that worked. So using the tips are like using the stopper at the leading haptic, prevent the slippage of the haptic, and leave the trailing haptic outside. So don't inject inside the lens completely, keep the trailing haptic always outside, and making the corneal tunnel closer to the second sclerotomy. So it is easy to engage the trailing haptic to the corneal tunnel into the needle, and you can actually use a iris hook in case if needed, if whenever the needle is coming in way, the iris is coming. And if the haptic length is more, you can trim it before applying the cautery. Thank you. And the complications actually glued, when earlier I used to do glued IOLs. So there the slippage used to be little more. But once I switched to the flanged IOL, I've never had a case of slippage. Maybe because that flange is there, which actually prevents the slippage of this. Because otherwise, whenever some patients develop an RD and all, when you try to do the surgery, the glued IOLs used to have a tendency to slip away even with a slight depression. But this doesn't happen with the flanged IOLs. I have not seen. And I make a PI in many cases because that actually prevents the optic capture and secondary glaucoma, especially in children. In almost all cases, I make a PI. And this case, only in cases where the pupil is already irregular and where you see that it is unlikely to close completely, I don't make a PI. Otherwise, all cases, I do a prophylactic PI.
Thank you so much, Dr. Divya. Indeed, practical tips. Our next speaker is Dr. S.J. Sai Kumar himself, the final word I would call in cataract surgery. He is the senior consultant cataract surgery surgeon at Giridhara Hospital, Kochi. He'll be talking on iris claw lenses, also the glued SF IOLs and the CMT flex IOL.
Thank you, Lakshmi, for having me in this course. And I thank my colleagues for helping me with my presentations and my videos. So we have basically spoken about anterior chamber lenses, the sutured scleral fixation lenses, and the Amane technique where we use a flanged IOL. So I'll be sort of mopping up, and of course the iris sutured, by which I think only JP sir can do. You know, it's a very difficult technique. I've tried it many times. It's not at all easy. You tend to buttonhole the iris, you cause iridodialysis, you cause bleeding from the iris. So probably I should do it slow like what JP always tells. Okay. So iris claw lenses were introduced in 1972, but it was used in between as a popular technique, but then it went out of vogue. And about the last decade and all, we have seen that it is gaining in significant popularity, and we use iris claw lenses quite a lot. There are some contraindications for iris claw lenses, which are almost similar to the anterior chamber lenses. So if you have gross abnormalities of the iris, you have large iris damage, aniridia, diffuse iris atrophy, rubeosis, active uveitis. So these are contraindications for an iris claw lens. The prerequisites are that just like in any other secondary IOL, you should have a good vitrectomy. You cannot have vitreous blobs and strands sitting in the anterior chamber, vitreous strand going into the paracentesis or the main wound and then try to push in an IOL. That should never be done. So a good vitrectomy is needed. Ideally 360 degrees, but definitely more than 270 degree of iris tissue is required. I have done in patients with some iridodialysis in one small area. If the remaining iris is good, I have done iris claw lenses, but probably not a very ideal situation. You can think of other options in such situations. It's a great technique for me in black cataracts in iris coloboma, because in colobomatous eyes, I'm sure those who have done colobomatous eyes, the eyes are extremely small eyes. You can't use the regular IOLs. Invariably, there will be some zonule loss. Many have a PC rent. So, although there is a coloboma in one area, with the remaining area of the iris is healthy, you can always go in for an iris claw lens. So this is slightly old video, but I'll just show you this technique. So, this was a patient who had a grossly decentered IOL with a bag complex. There was some, the vitreous is being removed here. And as I said before, vitrectomy is very, very essential. It is not absolutely mandatory to have a pinpoint pupil. I think that is something which we always think that we need to have very mobile pinpoint pupils. In fact, a very small pupil is a disadvantage to tuck in the intraocular lens under and claw it. So a mid-dilated pupil is more than enough for you to claw the intraocular lens. I also always do an inferior PI using my cutter. We have not had many pupillary blocks, but I always do that. And I place the lens in the anterior chamber first. This is a regular lens holding forceps which we use in our SICS, but now I have a modified iris claw lens holding forceps, which I feel is much better. I always use viscoat in the anterior chamber because that maintains whenever you have a problem with clawing, if you put HPMC, everything starts flowing out, the chamber collapses, you are in a big mess. So always have viscoat or any of the Indian equivalents in the anterior chamber before you go in for an iris claw lens. So once you've held the lens properly, you know exactly where to claw, and needless to say, the two paracenteses have to be well aligned. You lift up the lens, see the contour of the lens under the iris. Exactly at the center of the contour is your gap in the haptic which you enclavate the iris on. And one point which I forgot to mention was that before you put in the lens, just check whether both the haptics have the gap in between. Very rarely you can have defective lenses where one of the haptics, the enclavation gap is not there. You go and enclavate one. Secondly, the second haptic you try to enclavate, there is no gap there. So then you are in deep trouble. Taking out an iris claw is extremely difficult. Anup is nodding again and again. So, he is a very, very senior person who has done a lot of iris claw lenses. So, taking out an iris claw is a nightmare. So, make sure the lens is good before we go in for the lens. So, complications, again, ovalization of the pupil. About 50% I think will have some ovalization. You don't get exactly round pupils in all cases. Cystoid macular edema, late dislocation. These are all complications which used to be mentioned against iris claw lenses when we started doing this. But if you look at literature, all secondary IOLs have these complications. Whether it's a sutured SF IOL, glued IOL, anterior chamber IOL, iris claw, any of these, it's not the lens or the position of the lens that matters. It is the fact that you have done a lot of manipulation in the eye. You have done a vitrectomy. This is probably the primary cataract surgery itself was complicated. So these are all the factors which lead on to cystoid macular edema and any of this. And even sutured lenses can all, the suture can break, the IOL can dislocate late. So that percentage is sort of similar for all these lenses. To me, the advantage is that it's a safe, fast and effective technique, and most of the iris claw lenses can be done in the primary sitting. So even if you have an unplanned problem, an iris claw is always comes to your rescue. But of course, there is no foldable iris claw available as of now, so you have to have a slightly larger incision for that. So this is a small thing which Purnima mentioned, but I thought I'll just share a video. This is the Hoffman's pouch which we use for the sutured SF IOLs, where you don't open the conjunctiva at all. Make sure you don't start from the limbus. Starting from the limbus is a big mistake. You have to start from the clear cornea. You have to have at least a millimeter of clear cornea on before you go for the reverse tunneling, and you go through the conjunctiva when you go in with your sutures. In the classic technique, what you do is you raise a flap and then go in with the needle. Here you go through the conjunctiva, and once your IOL is placed there, you go into the scleral pocket that you have made, and you pull out the suture. So once that is done, you have the IOL well placed, you have the two sutures coming out of the pouch, and then you tie it, the knot goes inside the pouch. So this is a very elegant technique, or an alternative technique for the sutured SF IOL, where you don't open the conjunctiva and the eye looks very quiet the next day. Aniridia SF IOL is something that we don't use very regularly, but once in a while you may be required to use the Aniridia SF IOL. This is a huge IOL. I mean, once you take the lens out, you know how bulky it is, and you need a very large section to put in the IOL. The optic and haptic is very close because the lens is very large, and even a small bend can break the haptic. And these are all lenses that you don't get regularly. You have to order, have one lens, have one backup lens in the OT before you go in with your Aniridia lenses. So sutureless SF IOLs, as we all know, the original description by Shariat, then Dr. Agarwal modified it, became very popular. And this is the routine glued IOLs that we do, make a sclerotomy under the scleral flap. The biggest advantage obviously is that you can go in through a small incision. You don't need to make a large incision. You just need the clear corneal incision of your routine phacoemulsification. Grab one haptic and then grab the next one. This is what Dr. Divya mentioned, the difficulty of grabbing the second haptic. So the same difficulty is there when you do a glued SF IOL as well. Don't catch the middle of the haptic. Try to grab the end of the haptic so that the haptic is not damaged. You can make a small tunnel there, tuck in the haptic there, and then glue both the scleral flap as well as the conjunctiva. And one more thing that which have tried few cases recently is the CMT Flex IOL. The CMT Flex is a hydrophilic lens. So I was mentioning that there is no sutured claw available. This is a foldable claw available. So this is a foldable lens with an overall diameter of 13.75. You can see this T-shaped structure here, and this is what exteriorize out. So through a scleral opening, you can exteriorize the T portion there. This was actually a subluxated IOL. I initially thought of putting in CTR and doing a phaco, but then it was grossly subluxated. So my VR colleague helped me with the lensectomy. So this is the lens, and you go in through the sclerotomy there under a scleral flap, and you inject the intraocular lens there, and you hold the leading haptic. So you have to hold at the T area. It's a hydrophilic lens. It can easily get damaged. So you have to pull it out of this sclerotomy very, very carefully. And once the one haptic is exteriorized, then you have a special forceps with which you can hold the lens from the paracentesis there, and then go under the iris and go with the second sclerotomy there and take out the lens through the second sclerotomy as well. So in summary, IOL placement in the absence of adequate capsule support is a must for all cataract surgeons. It's not that, no, I can't do secondary IOLs, I'll ask someone else to do, I will refer it someone. I think it's not a very difficult technique at all. If you are a good cataract surgeon, if you are doing cataract surgeries in good numbers, you should also be able to do a good secondary intraocular lens. We need to be familiar with one or two techniques. I'm not saying that you should know all these techniques, but at least one or two techniques which is good in your hand, you should know, because these are techniques which help you save a lot of embarrassment with the patients for not implanting an intraocular lens. We have been talking about all these complications of, cystoid macular edema and, chronic iritis and things like that. But in my experience and with published literature, it is very clear that all these lenses have almost similar rates of all these complications. But we really need to analyze each lenses in a long term. And cystoid macular edema, retinal detachment, secondary glaucoma, these are all potential causes for subnormal vision in these procedures. So I thank you for your kind attention, and thank you, Lakshmi, for having me in this course.
Thank you, Dr. Sai Kumar, sir.
We have about 10 minutes.
Yeah, we'll have a active discussion, I think. Yeah. Keep your questions ready. All senior surgeons.
I will start the discussion with a question to Dr. Jayaprasad. Can you give a mic there, please? What is the viscoelastic that you always have in the anterior chamber during all these maneuvers? And do you have to frequently replace it? And
So for all my cataract patients, I use a dispersive OVD and a cohesive OVD. From Indian companies only, I use Orolab because the prices are less and they are doing extremely good. I do specular before in all my cataract patients, and at the end of 6 weeks, I repeat the specular for all my cataract patients to see how much damage we are doing, what has happened in a black cataract, how it is. So in these cases also, once again, I use only dispersive with cohesive.
Will a low specular count change your technique?
Less than 1,200, I will not venture in. I recently had a patient with bilateral severe pseudo-exfoliation, bilateral surgery done 15-20 years back, and then one IOL has subluxated, the other IOL has dropped back into the vitreous. Patient at 85, corneal thickness was normal, 510, 520 in both the eyes, but specular showed 700 cells. So there is another option called aphakic glasses, which I think we should go back to and prescribe to the patient, such patients. So below 1,200, I will not go in.
Any technique is?
You may go in for a scleral fixated, but I don't.
I would do an iris claw, because iris claw lens is very, very cornea friendly. There is absolutely no manipulation in the eye. Probably not with 700. That is too low for any patient, I think. Probably aphakic glasses are. But iris claw is one technique which I'm very fond of. It's a very easy, fast technique. Thanks.
Sir, I have a question. While putting the iris claw, left side inclination is quite easy. When coming to the right side, we can't really see the haptic where to.
No, that is because when you go in with your left, your lens is easily moving because it's not connected anywhere. So your first enclavation, if you are a right-handed surgeon and if you are enclaving the left first, it's easy to move. But when you go into the left, you already have the IOL stuck in the iris. So that is why your manipulation, space is a bit less. And whatever you put inside the chamber, even if it's viscoat or something, some probably escapes. There may be some oozing from the tunnel. So the visualization also slightly comes down. Once you place it there, you can actually first use an iris hook, normal Sinski hook, to just pull the iris, tuck the IOL under the iris, and then exchange your instrument with a sharp iris repositor, which I generally use for the enclavation.
Yeah, retracting the iris and getting that haptic down behind the iris is one option. And then once the lens is in the anterior chamber, you can go back and put a couple of sutures, make the main wound smaller. And then you go, because the forceps that he showed is actually smaller. Now we have broader ones, but with the smaller ones, can go through a 3 mm incision. So you can put a couple of sutures, close it so that the OVD doesn't escape. AC is well formed. We are also comfortable.
Can we really see that gap in between the haptics when?
Yes. You can just examine. Actually, some surgeons actually advise that before you put in the lens, you examine the lens under the microscope and use your forceps to just make sure that the gaps are there.
Yeah, I do that actually.
Yeah. So,
to ensure that, and the lens should be upside down. It should be upside down. It's away from the iris. That is another thing. And with the newer forceps, he has got it's slightly broader, two ends. So when you hold the lens, you hold it such a way that the tips are actually exactly across where the gap is between the haptics, so that you know where exactly is that gap. So you can enclave at that point.
I've tried
And
that forceps. Actually, we have that forceps, but it's a bit bulky.
too big.
It's too big compared to that.
Once that goes in, the visco comes out, that bulky.
Yes, madam.
You should close that wound actually. You should close that wound so that visco will not come out that much, and you should use a higher end dispersive and cohesive of it.
I'm Dr. Fatima from Maravindi Hospital, Tirunelveli. I have a question for Dr. Divya regarding flanged IOL technique. How do you judge how much to trim? Have you experience of, again to adjust the IOL at the end, again trimming again, flanging again?
No, if the flange doesn't happen properly, then if the length allows, then I do that. Otherwise, before even doing the flanging, I assess the length outside before doing the flanging. So in some eyes, whether the eyes are by the white to white diameter is small, then you see that there is a very long length of the haptic outside. Then you know that even when you push it, you have to really push inside. So the lens would actually move posterior. So trim it then only. Then you know, like at least a length of 1 to 1.5. So that would be the ideal, because you need to hold it with the forceps, and the tip, the flange actually, if you keep it little longer, you will see that it becomes still smaller and the flange would be like little larger. So 1.5 is more than enough.
It gets very well accommodated into your pouch, because the flange will be in a vertical stump kind of thing, no? So when you try to put it into the pouch, will it fracture?
No. Never come across, because that scleral, that's the reason why I started making a scleral pocket actually. So it just fits in there. So the length of the tunnel with the needle when you make it would be at least 2 to 2.5. 2 at least. So the scleral tunnel is actually 1. You just need something. If you make it a longer one, then it would slip back. So if it is a 2 mm tunnel, the 1 mm is the scleral, the pocket which you make, and the 1 is there where there is no pocket. So the flange will fit in the pocket, and the other length would actually prevent the IOL from slipping back. So that is what I do.
Thank you. I like to add one more comment regarding that iris claw question, because I have done quite good number of iris claw. The doubt was like how to manage the second haptic tucking. Some people will be comfortable in tucking right hand, some will be comfortable in left hand. Whichever they feel comfortable, that haptic they can finish off first hand. Because holding in, some will be comfortable in holding the IOL with their dominant hand. Some will be, so you can judge it and you can finish off that. You can reserve it that for the second haptic. Whichever uncomfortable, you will finish in the first hand. Thank you.
Thank you so much, ma'am. I have a question to Dr. Purnima. Is there any practical tip whereby we can prevent the tangling of the suture material in SFIL?
It's not a big tip, I think. Maybe just move the sutures to the edge of the tunnel on the side which you've already passed through the haptic. That should keep the sutures away from when you do on the other side. Just don't leave it lax so that when you pass the needle, it doesn't get in the way. So.
Can I ask a
Thank
question?
you so much.
Can I ask a question?
Yeah.
Yes.
Sir, as an anterior segment surgeon, SF IOLs and vitreous hemorrhage, is it a reasonable problem to consider? And do we need to always have a VR surgeon backup when we're doing these SF IOLs?
For routine SFIOL, you don't need any VR backup. Unless you're combining it with a major retinal procedure, you don't need to have VR backup.
So just anterior vitrectomy is enough?
Yeah, I mean, this is one of the things that I have noticed in the last, a few years. We all say that a good anterior vitrectomy is enough when you go in for an SFIOL, whether it's a glued one or a sutured one. But if it's not a completely vitrectomized eye, we are doing it on the table and we are handling it and not going behind. Many a times when you put in the needle, you can see small strands of vitreous you're pulling towards the center. When you pass either your needle or your forceps that you use for gripping the IOL, So I think there is some vitreous base disturbance that we are doing if it is not a completely vitrectomized eye. If it's a totally vitrectomized eye where the vitreous surgery has been done a few months back and then you are called upon to do an SF-IOL, that is perfectly all right. Because then until the vitreous base, they would have done a full vitrectomy. But in eyes where you have done only an anterior vitrectomy, I don't know the numbers or, I cannot quote any study, but I do have a feeling that we are making some disturbance in the peripheral retina by pulling the vitreous towards the center when we put in these instruments.
And hemorrhage, sir, vitreous hemorrhage?
In the presence of hemorrhage?
No, like how often does a small bleed happen into the vitreous?
Oh, very common. Because if you have not cauterized your tunnel properly, sometimes you can have small iridodialysis. When you enclave, you get the small dialysis, part of it goes in. So, but that's all very small quantity ones, which usually clears up in a few weeks.
So those can be left as...
I think so. Unless it's a huge, bleed filling the entire vitreous cavity, normally they can be left and they usually get absorbed in a few weeks' time.
I think it's time to wind up. Thank you for the active participation. It was nice talking to everybody. Thank you.